I'm going to talk about rounding on the inpatient psychiatry wards, how to do it efficiently, how I do it. I've tried lots of different ways trying to seek efficiency and also just being able to maintain something that's sustainable in terms of a not burning out aspect. I have had the chance to work on very high volume psych wards. In my old job, I do some moonlighting and have to round on 30 something patients and sometimes seeing 10 or more admissions in a day. And so efficiency became super important. Don't recommend that. My new job is capped at 12 patients, and I work in a freestanding psychiatric hospital. So we don't have the amenities of a full general hospital in terms of medical tests available and consultants available. So that makes send out decisions difficult sometimes. But I want to talk about three different models for rounding. I think the most common model is, and this might be different for trainees, depending on what your attending wants you to do. The most common model is probably where you show up, you might do a little pre-charting, either first thing in the morning or some attendings might do some pre-charting the night before. And then you just go start seeing your patients. You print out your patient list, you go see patients in some order. You might jot some notes on your patient printout or just try to remember them. And, well, I guess before that, you might have had some sort of brief staff meeting where you get a report from the nurse and then you go see your patients. So you just try to go see them all. And then you go back and put in your consults, put in your orders, and then you start working on your notes for the rest of the day. And of course, you'll have to deal with little fires that crop up throughout the day, but that's the general workflow. That's what I do sometimes, but I found that I get really burned out doing 12 or more notes all in a row late in the morning or the afternoon. I just lose focus. It's just painful. So another model is where you go see each patient one by one. And as you see them, you are either typing notes in the computer. So if you're able to, if the patient is calm enough, you bring them into the meeting room where they have computers, and you're able to type notes there, or you can type notes immediately afterward and just do all of your orders, do everything that needs to be done for that patient for that day as best you can, basically while they're with you. And then you go get the next patient to do the same thing. I've actually found this way of routing to be the best for me personally. Sure, it takes longer in a sense. Like I won't be done seeing patients until sometimes the early afternoon. Whereas if you just round on your patients in the morning, you can usually finish seeing all of your patients well before lunchtime. And then you just have your notes and orders and stuff to do. But once you're done, right? So I might not finish seeing all my patients until say 2 p.m. or something like that. But once I'm done, then I've already got all of my work done. I've got my notes in, I've got my orders in, everything is done. And I find that way to be much less painful. It just kind of breaks up the flow. It just makes me feel like I'm making more progress and that I don't just have a pile of notes waiting for me. So that's been helpful. And then there's sort of a mixed model where in the morning, instead of doing just a brief pre-charting, you actually do kind of a deeper pre-charting and prep all of their notes and do basically their entire notes as best you can, except the subjective portion. Because for most of your patients, based on the nursing report, based on their trajectory from yesterday, you probably know what you're going to do with their orders for most of your patients. So you can even update their orders, prep their note, and almost entirely except for the subjective portion. And then you go round on all your patients. And then when you're done, you still have all your notes to do, but it's much less time per note. So that's kind of my second favorite. My least favorite is actually just seeing all the patients at once and then having to do all of my notes. In the one hand, it feels good to be able to say, "Oh, I've seen all of my patients, and worst case scenario, I can finish my notes at home." But just psychologically, it just burns me out having to do a bunch of notes all at once. One thing that I try to do for all my patients is be systematic as to how I'm approaching them. And I have this acronym that I came up with called FLOP SEND. That's FLOPSEND. The F stands for flowcharts because that's usually the part in my EMR where you check vitals. And so basically that's my mnemonic to remember to check their vitals, check with their most recent vitals. What's the trend? Is my patient on clozapine getting tachycardic? Things like that. L is for labs, check if they have any new labs. O is for orders. In my EMR, sometimes the orders like expire, they auto expire. So checking, make sure all the orders are accurate, up to date. Putting in consults, putting in new orders, putting in lab orders. P stands for problem list. So I write problem-based notes. And so sometimes I forget to add a problem like, oh yeah, they've got hypertension. Let me make sure that's in my note and that I've got that as part of my problem list. S is for sleep because I consider that to be sort of a psychiatric vital sign. And so I want to check the nurse report that is recorded in the chart as to how many hours of sleep they got. If they're getting minimal hours of sleep, that's something I need to do something about. E is for events, and that just refers to overnight events. Were there any episodes of restraints or seclusions or emergency PRN medications? So that's just a check mark to do my note. D is for discharge planning. I always want to be prepared for discharge. Where are they going? What kind of aftercare are they going to have? How are we going to do relapse prevention? Things like that. So those aren't necessarily in the right order, but it's sort of a mnemonic checklist that I go through for each of my patients, and that helps me. And then the last mnemonic that I want to leave you with is mind space. Mind space is a mnemonic I came up with to help me with the differential diagnosis for a new psych patient. So that's MINDSPACE. So basically, this is a mnemonic you might use to just, help you be systematic in terms of your differential diagnosis. If someone gets admitted, say involuntarily due to erratic behavior in the community, that could be due to a lot of things. So the M stands for mania or manic depression. So one common differential in the inpatient setting is bipolar disorder. I stands for intoxicant, so substance-induced disorders. N stands for neurodegenerative, so dementia, traumatic brain injury, those kinds of things. D stands for developmental, so these are neurodevelopmental conditions like autism or trisomy 21. S stands for schizophrenia spectrum disorders, another big category for inpatient psychiatry. P stands for personality or personality disorders. A stands for adjustment disorders. So did just something bad happen to this patient and they're just having a severe reaction to it. C stands for catatonia. And again, catatonia is always a secondary phenomenon. So if someone has catatonia, that should still make you think of the primary diagnosis, but just helps remind you not to miss it because it is more common than we often think it is on the inpatient unit. And then E stands for encephalopathy. And so you're going to want to consider that for folks for their orientation might be disturbed. They've got some signs of memory impairment or signs of attention impairment. All right, that's it. Hope that's helpful.